Hello everyone. In the next few videos, we'll be reviewing several panoramic radiographs. As part of the Summer Interpretation Seminar course, you will have to participate in 5 panoramic radiographic interpretations. The first radiograph is about identifying the features of a simple bone cyst. This radiograph was sent to me by Dr. Carlin Weimers, an orthodontist. Before you start interpreting a panoramic radiograph, evaluate if the patient positioning is correct. A panoramic radiograph can have many kinds of positioning errors. You should look at the occlusal plane, which should have a mild curvature, a very slight smile. There should be a bite block, and the posterior teeth should not be in occlusion. So this is good. The right and the left teeth should be similar in size, which is also good in this radiograph. The right and the left ramus should also be similar in size. The hard palate should be almost horizontal, similar to this radiograph. The posterior border of the ramus should be inclined towards the back of the image. The hyoid should not superimpose over the body of the mandible. The dorsum of the tongue should be in contact with the hard palate. This is a very common error. On this radiograph also, the dorsum of the tongue was not in contact with the hard palate. Therefore, analysis of the periapical region of the maxillary teeth becomes difficult. Other than this tongue position error, this panoramic radiograph is excellent for interpretation. The linear band that we see here is the head positioning guide. The shape of this guide varies from machine to machine. As part of the standard protocol, you will begin your interpretation in evaluating tooth number 1 to tooth number 16. Then from number 17 to 32. This way, you will not miss radiographic findings. You will review all the teeth. Then you will come back to the area of interest. You may have a different standard protocol, starting from the right maxillary central incisor to the third molar, then from the left maxillary central incisor to the third molar, then mandibular central incisor to the third molar on the right side and mandibular left central incisor to the third molar. Or you may even have another protocol. Whatever you do, always follow the same protocol. Following a standard protocol regularly is critical for good diagnostic result. To save time today, we are going directly to review this radiolucency. This oval radiolucency is slightly bigger than the molar crown, is superimposed over the roots of the canine and the lateral incisors. This radiolucency is well corticated. The canine and the lateral are not displaced, not separated. You can also appreciate the lamina dura and pedial spaces of these two teeth. These two teeth are not carious. There is no history of trauma. Clinically, both the teeth are vital. If these teeth were non-vital, we could have considered a radicular cyst as a possibility. For a radicular cyst, the pedial spaces would not be intact. For a lesion of this size, a radicular cyst is likely to separate or displace the roots. I have a CBCT scan of the same patient. Let's review that to see if the cortical plates are displaced. This is the small field of view CBCT scan. A small field of view CBCT scan is appropriate because the defect is localized only in the mandibular anterior region. This blue line here represents the image on this screen. I am going to scroll through this image. As I come mesially, here I pick up the radiolucency. You can appreciate that the buccal cortical plate is thin but not expanded. This defect almost reaches the lingual cortical plate, and the lingual cortical plate is also intact. If I scroll further, that's the defect. It's radiolucent, labial cortex is thin, lingual cortical plate is intact. On the axial slices, here is the defect. The defect is rather linear rather than being a circular defect. No expansion of the buccal or lingual cortical plate. Please remember that this defect is more linear than being circular, although in this view it looks like circular radiolucency. So coming back to the panoramic radiograph again, this is the radiolucent defect that we saw. This defect goes between the two roots. So this is a simple bone cyst. Simple bone cysts can have several names. Most common is simple bone cyst and traumatic bone cyst. These defects do not have epithelial linings. Therefore, a cyst is a misnomer. It's also known as hemorrhagic bone cyst, although there is usually no blood inside such a defect. A better name is probably an idiopathic bone cavity. It tells that it's a cavity in the bone and we do not know the cause. As we just mentioned, the etiology is unknown. The current assumption that it's a variation of normal development, there is no evidence of relationship with trauma. Therefore, the name traumatic bone cyst is a misnomer in two ways. It is not related to trauma and it's not a cyst. The clinical features of simple bone cysts are quite unique. It is a common condition. Mostly you will see it in 17-year-old boys. It can also happen in girls in similar age, but more common in boys. Usually it is solitary, but can be multiple. The teeth adjacent to this defect are vital. Usually a simple bone cyst is discovered by chance during a radiographic examination because the patient has no signs or symptoms. The vast majority of simple bone cyst is in the mandible. Although our case shows a lesion in the incisor canine area, more commonly a simple bone cyst is detected in the posterior mandible and in the ramus. The border of these defects can be corticated or non-corticated. In our case, the border was mostly corticated. One finding that is the defect scallops between the roots of the adjoining teeth. Here is a simple bone cyst in the right ramus. The third molars are incompletely formed, about 17 years age. Here is a simple bone cyst in the left molar region. The defect is scalloping between the roots. The third molars are again incompletely formed, about 17 years age. The first and second molars are not displaced. The defect is longer mesiodistally than being circular. Continuing with the radiographic features, a simple bone cyst is uniformly radiolucent. Most of the time, as we saw in these radiographs, the teeth are not displaced. Occasionally, tooth displacement can happen. If you review a simple bone cyst on a CBCT scan or an occlusal radiograph, most of the time there is no cortical expansion. As we have seen in our case and on the panoramic radiograph, this defect may grow along the length of the bone instead of a circular expansion. The diagnosis of simple bone cyst is primarily dependent on radiographic features, followed by surgical findings. Histopathological examination is difficult because mostly there are no tissues that can be harvested. It's a cavity. The radiographic findings are often similar to odontogenic keratocyst. If the adjoining teeth are carious, we should also consider radicular cyst, particularly if the lamina dura is lost. Although most simple bone cysts occur in patients in their second decade of life, occasionally simple bone cysts will also appear with periapical cementoosseous dysplasia in middle-aged women. A simple bone cyst may not require any treatment, and it may spontaneously resolve. This is one reason probably that a simple bone cyst is not detected in patients over 20 years age. If a patient is not imaged around age 17 or 18, a simple bone cyst may have happened in the jaw and then may have resolved by itself. Therefore, when you image a patient around age 20 or 22, you may not see a simple bone cyst. However, the current approach is a conservative surgical opening with careful curettage. Usually, this is sufficient to initiate healing of the defect. Recurrence of a simple bone cyst is rare, but it can happen. That's it about simple bone cyst. Shukran. Thank you. Please come back again for another video.